Welcome, everybody. This is the workshop on novel nutrition and GI topics. I'm Judy Fulton. I'm a dietitian from Children's Hospital in Colorado, and I'll be one of the moderators today. I'll be also moderating with Rachel, and Rachel Kofsky is from Children's Hospital of Philadelphia. She's also a dietitian, and we welcome you all. Thank you.
We have some amazing speakers here today. We're on a tight schedule. The layout today will have 15 minutes for presentations and then 8 minutes of question time following each speaker. And then if we have time at the end for additional questions, we'd love to get to those for you. If you want to submit your questions through the app, you're more than welcome to. If you want to ask one in person, just make sure you go up to the mic so that the recording can get your question nice and clear. So that when we hear the answer, it's nice for everyone who's listening from afar. First up, we have Lucia Ramirez from Emory in Georgia, and she'll be talking to us about clinical outcomes and body comp for adults. Welcome.
So good morning. Thank you so much for the invitation. As mentioned, my name is Lucia Gonzalez Ramirez from Emory University, and there are no relationships to disclose related to this presentation. And let's begin with the background. New therapies for people living with cystic fibrosis, for example, hemp, and the increased associated lifespan has raised potential health concerns in this population. For example, musculoskeletal disorders, weight gain related to hemp, diabetes, among others. Also, nutritional status has been linked to clinical outcomes. However, when conducting assessments, we have encountered some limitations, including that BMI fails to differentiate between body composition components and does not provide information related to muscle quality nor function. Furthermore, standardized techniques such as MRI, CT scan, and DEXA are not commonly available. This has created the need to integrate user-friendly, portable, and inexpensive techniques into nutrition assessment. And some good examples are hand grip dynamometry that measures muscle strength and bioelectrical impedance analysis, or BIA, that estimates body composition components and measures cell quality and muscle quality. Like any other method, they have strengths and limitations. Unfortunately, today we're not going to discuss that because of the time constraints. However, I would like to mention that phase angle uses electricity to assess body composition. Particularly, it uses impedance, which is composed of resistance and reactance. When we plot these two raw measurements, we obtain the phase angle, which is the actual indicator of cell membrane integrity and cell quality. The beauty of phase angle is that it is independent of traditional regression equations that often relied on demographic and clinical data. Last year, during the NACF in Phoenix, I presented results from a study where we compare muscle characteristics between people living with cystic fibrosis and healthy controls. We found that the people living with cystic fibrosis had a lower muscle mass, lower muscle quality, and lower muscle strength. In this current study, we aim to assess the relationship between clinical outcomes and indicators of muscle mass, muscle strength, muscle quality, and body fat in adult people with cystic fibrosis with normal versus low muscle mass. Now let's turn to the method section. This cross-sectional study involved 75 adult people living with cystic fibrosis from 3 cohorts, with different research questions but similar methodologies. And actually, 2 of these studies have ongoing recruitment. We also categorize participants by low muscle mass and normal muscle mass for further analysis. We measure muscle mass using DEXA. Particularly, we use appendicular skeletal muscle mass, which is the sum of the skeletal muscle mass from both arms and both legs, and subsequently we corrected by height to obtain appendicular skeletal muscle mass index, or ASMI. We define low muscle mass using the European Working Group on Sarcopenia in adults cutoff points, and we also measure visceral adipose tissue mass and total body fat percentage. We use BIA to obtain face angle and body water components, and hand grip dynamometry to measure muscle strength. Our clinical outcomes included lung function as measured by FEV1% predicted, physical functionality via the 1-minute sit-to-stand test, and finally, fasting plasma glucose to our plasma glucose, and the Matsuda index for insulin sensitivity. We obtained these parameters using a 75-gram OGTT. The statistical analysis included the assessment of the differences between groups, the quantification of the relationship between the body composition indicators and clinical outcomes, and the assessment of confounders and effect modifiers. Now let's jump to the results. In this table, we can see that the variables were divided in normal muscle mass and low muscle mass. And some of the highlights related to this demographic and clinical data include that the low muscle mass group were mostly homozygous for delta F508, whereas the normal muscle mass group was mostly heterozygous for this same mutation. More so, 2/3 of the participants in the normal muscle mass group were CFTR modulator users, whereas in the low muscle mass group, slightly more than half were users. Also, participants in the low muscle mass group had lower BMI, lower muscle strength. In contrast, they also had higher body fat percentage. As we can see here, also the low muscle mass group exhibited lower body water components. In this table, we can see the correlations between body composition indicators, which are on top, and clinical outcomes in the first column. Statistically significant correlations are colored, negative correlations are in blue, and positive correlations are in pink. And please note that correlations related to ASMI and lung function are not significant. However, I will return to this point in a few slides. But before that, let's look deeper at the information in this table. Lower face angle was related to worse insulin sensitivity as measured by Matsuda, and worse glucose tolerance according to our plasma glucose values. So this suggests that face angle may be a good indicator to assess the metabolism of carbohydrates in the adult people living with cystic fibrosis. Similarly, lower muscle strength was also related to worse insulin sensitivity and worse glucose tolerance. And again, once more, this suggests the importance of conducting a more comprehensive analysis of the muscle characteristics in adult people living with cystic fibrosis. As expected, higher fat percentage was related to worse physical functionality as measured by the 1-minute sit-to-stand test, and worse insulin sensitivity. Earlier, we discussed the CFTR modulator status, which modifies the relationship between lung function. Here in this graph is in the y-axis and muscle mass in the x-axis. CFTRs, it's indisputable that they have an effect on lung function. And maybe this is why we are seeing this interaction among CFTR modulators users, it's represented by the solid line. The relationship between these two variables is positive. However, among non-users, the relationship is blunted. And again, this brings us and shows the importance of conducting a more comprehensive nutrition assessment that will lead to a more individualized treatment in our adult people living with cystic fibrosis. Similarly, BAT modifies the relationship between Matsuda index, which is the insulin sensitivity in this graph in the y-axis, and muscle mass in the x-axis. And again, if participants have a normal or lower BAT mass, the relationship, which is represented by the dotted line, it's positive. However, for those participants that have a higher BAT mass, the relationship is blunted. Now I would like to share our conclusions. People with cystic fibrosis with low muscle mass exhibited decreased muscle strength compared to those with normal muscle mass. Higher face angle and hand grip strength were associated with improved glucose tolerance. Higher adiposity was associated with worse physical functionality and insulin sensitivity. BAT mass alters the relationship between insulin sensitivity and muscle mass. CFTR modulator use diminishes the relationship between lung function and muscle mass. However, longitudinal studies are needed to determine the causality between body composition indicators and clinical outcomes in the adult people living with cystic fibrosis. To summarize, access to CFTR modulators has improved life expectancy, but also raises new potential health concerns in this adult population. Currently, we have an increased access to portable and inexpensive methods of assessment, including BIA and hand grip strength. And these can be used in the nutritional status and clinical outcomes assessment. Thus, this makes us to rethink the approaches in the nutrition care process in adult people living with cystic fibrosis. Also, we may need to refine the clinical outcomes of interest to address the needs of these patients, not by removing the endpoints that we currently have, but by diversifying these endpoints. And in the future, this shift will conduct us to an individualized medical nutrition therapy in our adult population living with cystic fibrosis. I would like to give special thanks to my commenters, Dr. Jessica Alvarez and Dr. Thomas Ziegler, and the A2C Nutrition Lab at Emory University. Thank you all so much, and I hope to see you during the poster session at poster 602.
I have one question since I'm in pediatrics, and how would you think of starting to standardize these measurements in the pediatric population?
Yeah, actually, that's a great question because although I was focusing on the adult population, these also can be applied to pediatrics because they also have access to CFTR modulators. They also may have new concerns like weight gain, but also even though they are not categorized like undernourished, they may have some musculoskeletal disorders that are hidden by the use of CFTR modulators. So now these methods are not standardized for pediatrics, but it's a good it's a good start, and you can start using these new methods. Well, they're not new, but these more accessible methods, and you can conduct research, and maybe one of you are going to be the one who is going to validate these methods, or maybe our lab, and we in the future are going to be using these also in the pediatric population. That's very good.
Thank you. I have one more question. So, being at a large pediatric center, we have a lot of different team members. And I know our physical therapists had talked about doing the hand grip strength and us doing other measurements. I'm curious, when you were doing the adult work, if you had the dietitian or if you had other physical therapists, other team members doing the measurements.
In this case, the dietitian or the clinical coordinator is the one who conduct these tests. But the beauty of these tests is that the training is minimum. It's very user-friendly. It's non-invasive. Now they're very affordable. So we can bring this to clinical practice and not just for research. And then we can have a more comprehensive assessment and monitoring of our patients. So I encourage you to use these methods. It's very easy. Just will take you one day maybe to train your staff, and then you can apply them.
Okay, we have a question that came through on the app. Do you feel actually, it just disappeared. Sorry. Okay. Was C-peptide considered as a method of evaluating fasting glucose?
Yes, we think that would be a good confounder or something that we can bring into our statistical models. In this moment, like currently, we are not including that in our analysis, but that would be a good thing to bring into our analysis. As like a few years ago, we were not thinking about CFTR modulators as interactions or modifying our relationship between our outcomes, but now we know that we need to consider them. So that's something that we can bring into our analysis. Not now, but we can do it in the future.
Okay. One last question. Do you feel assessment of body composition will help teams change the focus away from weight, BMI, quality, not quantity?
Yes. I mean, BMI, it's a very fast way to screen our patients, but we shouldn't be just using BMI. That's why we have these all other methods, and then we can have a more detailed and informed assessment, and then these will inform our therapies. So yes, we need to move away just from the global weight and start looking to the components of body composition and have a more integral assessment. So yes, that's gonna be shifting us forward to a more comprehensive assessment.
All right. Thank you. All right. I think that's it.
Thank you so much.
Next up, we have Dr. Juliana Bailey. She comes from to us from Alfred Health in Melbourne, Australia.
Hello, everyone. Thanks so much for having me today in this workshop. Today, I'm going to present on assessing dietary patterns and composition among adults with cystic fibrosis taking modulator therapy. They're my disclosures. So to start off with some background, I think we're all very familiar with the legacy high-fat, high-calorie diet recommended for CF. In combination with this, we've also observed increased fat intake on highly effective modulator therapy. Dr. Stallings published some work about fat intake increasing on ivacaftor, and we've also seen this with ETI. We've also all heard the anecdotal reports of patients taking in a lot of extra grams of fat to ensure that their modulator is absorbed. This is happening on a background of baseline poor diet quality. A recent systematic review found that people with CF have excessive energy intakes with diets that are low in micronutrients and poor in nutrient density. Alongside this, overweight and obesity is also increasing in the CF population, and this is potentially accelerated by highly effective modulator therapy and the rapid weight gain that this causes in some patients. So these concerns over diet quality and the unintended rapid weight gain on modulators are contributing to metabolic risk factors, including increased cholesterol on modulator therapies, as well as hypertension that's been observed on tricep. So there's also no evidence for how much fat is required for modulator absorption. So with that, the aims of our study were to evaluate dietary goals, knowledge, and reported changes in response to initiation of CFTR modulators. We also wanted to determine diet quality of baseline intake in a patient cohort that had been taking ETI. And we also wanted to assess changes in diet quality on different diet patterns in response to nutrition education intervention. So for our study design, we started with a cross-sectional web-based survey that assessed changes on modulators with respect to diet. Our survey had questions about knowledge level of fat-containing foods, and we also wanted to understand practices of patients with their diet intake on modulators. After this, we recruited a subset of 10 patients to a pilot and feasibility study of 2 different dietary patterns and those effects on modulator concentration. So each diet pattern was the general healthful diet and the high-fat classic legacy CF diet, and participants followed each of these diets for 7 days. At their first baseline visit, we had them fill out a baseline 3-day diet record, and at their second visit, they were randomized to either the high-fat diet or the general health diet. They underwent diet education from our study dietitian, and then were asked to fill out 3-day diet records while they followed the diet. At the third visit, they switched diets to whichever one that they hadn't been on in the first instance. Again, they underwent diet education and filled out a 3-day diet record. So we recruited our patients from the University of Alabama at Birmingham Adult CF Clinic, and we had some optional participation in our survey from the Southeastern Research Cooperative. We aimed to have participants that were 21 years of age and older who were taking ETI. Our goal was to have 10 participants in the diet pilot and feasibility study, and our goal was to have 100 survey responses, and we only got 80. To say a little bit more about the diet education intervention, for the general healthful diet pattern, we counseled patients to take in 30% of calories from fat or less, and we were able to provide them with a fat gram range in order to guide them in selecting their choices. It's kind of hard to conceptualize what 30% of calories from fat is if you're not a dietitian. So the fat gram range was just meant to provide them extra guidance so they could be more adherent to the diet therapy. And this was based on either their baseline diet record or on a diet recall that we did. We provided them written information on this as well, and the education took place over telehealth. For the high-fat legacy CF diet, this was 40% of calories from fat or more, and we gave them the traditional CF diet education that all of the dietitians in this room will be very familiar with. We also gave them written information on this diet pattern as well. For our analysis, we used Nutrition Data System for Research for diet record analysis, and we had SAS code to generate the Healthy Eating Index provided by the National Cancer Institute. The Healthy Eating Index is a validated measurement of diet quality that compares someone's intake to the dietary guidelines for Americans. It's scored on a scale of 1 to 100, with 100 being the absolute best score you could get. We did descriptive statistics for our survey and had paired t-tests to analyze diet intake changes. We had Pearson correlations to determine relationships between diet intake and body comp parameters. And we used Stata and GraphPad Prism. So we were able to get 80 survey responses in this graph on the left. It was an anonymous survey, but we collected some basic demographic information, including type of insurance, race and ethnicity, education level, employment. And our mean age was 37 on our survey respondents, and 60% were female. And here on the right, this is our pilot and feasibility subset. We were able to recruit 10 patients, and the median age was about 30, with an age range of 22 to 53. 80% of our patients were white, 50% were female, and The mean BMI in this cohort at baseline was 24.5, so on the higher side of normal. And not pictured on this graph, but I'll speak to it, 60% of the patients in our cohort had CF-related diabetes, and 100% were pancreatic insufficient. So for our survey data results, we had 80 responses, and 42% reported that they changed their diet since taking modulators. In this table, I have pictured the types of changes that they reported making. Half of the respondents had reported decreasing their calories, 55% reported decreasing total fat, 64% reported reducing sugar, which as a dietitian made me very happy to see. There was also about half the cohort that reported an increase in fruit and vegetable intake, and 42% had decreased their portion sizes. Not surprisingly, 72% reported that they had gained weight on ETI. We also asked about participant goals, both pre-modulator and how their goals had changed while taking the modulator. You can see here, pre-modulator goals are in the blue and on-modulator goals are in the orange. And the 35% of patients had a goal of weight gain prior to ETI. This had come down to 12% on modulator. And then in comparison, we also saw an increase in proportion of patients who wanted to either lose weight or maintain their weight on modulators. And interestingly, we had an increase in proportion of patients desiring a weight neutral approach where they could focus on diet quality without having specific weight goals. We also asked if participants were taking modulators with a fat-containing food, and overwhelmingly, the majority, 86%, reported that they were. Then we asked further, do you know how many grams of fat you're taking with your modulator? And 66% said no. Of the 34% that said yes, about half of them were taking their modulator with 10 to 20 grams of fat. 29% were taking it with 21 to 30 grams of fat. And then 17% were taking it with less than 10 grams. We also asked some knowledge-based questions on fat. We asked participants to select foods that contained fat, and then we also asked them to select foods that contained either saturated fat or unsaturated fat. And the results were pretty surprising. This is a graph that shows the number of questions that participants got wrong, or the number of foods they misidentified as fat-containing when they were not. So we can see that only 30% up here in this brown bar, sorry, this mouse is not great, where only 30% were able to correctly identify fat-containing foods. 21% could not identify any saturated fat foods, and 28% couldn't identify any foods that contained unsaturated fat. This was pretty surprising given that people with CF meet with dietitians regularly, and we would assume that they're getting lots of nutrition education, particularly around fat and fat intake. So I'm glad we asked these questions. When we looked at our diet intake records, we found that when participants switched from the high-fat diet pattern to the general healthful diet pattern, that there was a decrease in total calories, total fat, and saturated fat, which is good, and it's not surprising. It means they listened to our education intervention. And then we also assessed the healthy eating index, that validated measure of diet quality. And we found that the healthy eating index significantly increased on the general healthful diet, both from the baseline diet and when participants were following the high-fat diet. We wanted to look a little bit further at the healthy eating index. So this is a radar plot that shows all 13 components of the healthy eating index. And each component is like a spoke of this wheel. So starting at total fruits and going clockwise down to fatty acids, which is essentially unsaturated fats, these are adequacy components. Higher scores on these mean higher intake. When looking at refined grains, sodium, added sugars, and saturated fats, these are considered moderation components, and higher scores equal lower intake. So we are able to graph the diet patterns, and this is what our participants' baseline diets looked like. This was a healthy eating index score of 43 out of 100, And you can see here that it is high in sodium, with it being a lower score. We would expect that because our people with CF have been counseled to eat a high salt diet. Also moderately high in added sugars and high in protein, which again, our patients have been hearing the message to eat a high protein most of their lives. It's quite low in fruits, vegetables, whole grains, seafood, and plant protein. And then this is what their diet looked like when they switched on to the high-fat diet pattern. It's strikingly similar to their baseline diet. And then this is how things changed when they went onto the general healthful diet pattern. You can see here that saturated fat intake and added sugar intake decrease along with refined grain intake as they moved outward. Sodium intake stayed about the same. And then we also had an increase in fruits, vegetables, unsaturated fatty acids, and even a small increase in seafood and plant protein. So in conclusion, half of our respondents reported making healthy diet changes on modulators, but we did find nutrition-related knowledge deficits, particularly around the fat content of foods. Participants had poor diet quality at baseline, lower than the US general population, and diet quality improved significantly after short-term dietitian education on a general healthful eating pattern. Our study did have limitations. This is a pilot and feasibility design, and we had a very small sample size of 10 participants for our diet records. This was primarily conducted in a single center. We had a short intervention time period, and we also think that participants might have been primed for the diet education by the survey that they took that asked them knowledge-based questions. So we do have a need for targeted basic education on a general healthful eating pattern in the clinical setting. Future studies should be designed to identify the lowest amount of fat needed for modulator absorption. Our study was not powered to determine that, but larger prospective studies could be designed to find that information. And we also need larger prospective interventional studies to understand the impact of nutrition education and behavioral counseling interventions for improving diet quality on modulators. I wanted to acknowledge, firstly, the participants that generously gave their time to be in our study, and my co-principal investigator, Dr. Jennifer Gimbalot, as well as the rest of my UAB team, especially Dr. Natalie Rose and Justin Anderson, who helped with the recruitment and data analysis. With that, take your questions.
Thank you, Juliana. What a great presentation. One question that came through, if there is no studies with a recommended amount of fat with ETI, what advice would you give to the clinicians when they're discussing diet education with their patients?
That's a great question. I think that, our product inserts have examples of foods that participants in the clinical trials took their modulators with. They didn't quantify the intake in the clinical trials or record any of that, but I think it's fair to educate patients on those types of fat-containing foods. And I think it's okay to be honest and say we don't know exactly how much fat you need to take this drug with, but we know that it requires some fat to be absorbed because it's lipophilic and it's more effective that way.
Hi. I'm short, but I just wanted to say thank you for doing this research. I am a research coordinator for Boston Children's, and we're currently working with the Strong CF study, and we have been, doing interviews with people, and I just wanted to highlight some of the points that had come out, that, people really, even though they are getting all these interventions, they are having these talks, they don't know what they should be eating. They don't know what foods work for their CF-specific diet. What happens when they also have CFRD? And then I had one other thing I wanted to say, but, exercise. Like, a lot of people right now, at least from who I'm talking to, how can I eat and exercise? What exercises help me with my disease, and what exercises do I need to help maintain good health? So I don't think I had any questions, but I just wanted to say thank you for doing this work, and that I'm hearing it on the front lines too.
Thank you so much for your comments, and I appreciate the work you're doing.
Steve Friedman from Harvard. This was great. How much do you think we have to do to convince patients for these healthy diets? And and in part, it's, I think this is a whole new era we're now in, thinking about CF and aging. And with our group, we're now spearheading a lot of that. But I think we have to be looking at cardiovascular disease, things like that. So diet is not only kind of acutely probably playing a role here, but for the first time ever, which is great, we have to think about what happens 20, 30 years from now, high saturated fat diets, things like that. So did that, I don't know if you put that in as you were trying to educate patients in your process?
I can speak a little bit to what we do in clinical practice too. I know a lot of us are getting fasting lipid panels as part of our annual labs now, and that really helps us counsel patients when we can see something other than weight, when we're looking at cholesterol and looking at triglycerides, and we can help patients make a direct link between their diet quality and their heart health. I also think that any diet change is a really complex set of behaviors, and that's tough. Like, that takes time, and things with food and diet, they're not dichotomous behaviors. There's so many different things and steps people have to take to form new habits, and it's a long process. And so I think that we don't really know the best way to go about it in this cohort. So I'm so happy to hear that people are doing qualitative work to bring more patient voice into how we should design these behavioral interventions to be most effective for our people with CF. Thank you for your comments, Steve.
I think that's such a great question, because I think that our families need, and people living with CF may need lots of help, just depending on, now that they're, in air quotes, eating a diet that's recommended for all of us. What kind of skills do they have? Do they still have a high treatment burden? So they're not only thinking about preparing different foods, but always still needing to clean their equipment and do treatments. So we are piloting a culinary medicine program, and I'll let you know how it goes. We've had one session so far. We are really, really fortunate to have a chef on staff. So we'll see. To be continued.
That's amazing. I can't wait to see your presentation at the next conference.
Anne-Marc from France. I just wanted to emphasize how important it is to start at pediatric ages. It's much easier, and we have to deliver adult patients to your adult CF centers with a better knowledge on what are fat and how they are. So because now we have less severe patients in our pediatric teams, we really need to work on that. Thank you. Thank you very much.
Absolutely agree. Yes.
Hi, my name is Paula Garvey. I'm from New Hampshire, and I'm coordinator for the Patient and Family Advisory Council at Dartmouth. And I have a 26-year-old daughter with cystic fibrosis. And also I'm a culinary and nutrition teacher, so there's a lot of things going on.
Amazing.
But I have a huge interest in nutrition and where we're going with nutrition. We, as a PFAC, we got a Patient Family Advisory Council. We got a grant from RockCF, and we thought we were doing a fantastic job. We had a program. We were giving out grocery cards. Our dietitian made videos, and we got goodie bags, and we wanted our patients to get involved. We had really poor participation, and we put a lot of work into it, and it's fantastic. It's on TikTok. It's really good. But and I did tune into the culinary medicine program, and I think that is so good. It was so well done, so professional. So I think at this stage, what we need to do is, how do we get the information? How do I get my daughter? And she pretty well knows what to eat, but how do we actually get that information to our patients and families? I think that's the next step.
It is. And we did do a set of interviews along with this research that was presented in a session yesterday to get that qualitative element. But I do think that we need more mixed methods research for intervention design, because as clinicians, we can come up with what we think is going to work all day. But if we don't hear from the patients and have them co-designing these interventions with us, I don't think they'll be effective or sustainable.
All right, Juliana, there's a question that came through that I think screams your name. What recommendations do you have for educating families on diet quality who struggle with food insecurity?
And that is a huge challenge. I think that we have a lot of good resources on how to have a healthy diet on a budget. And I think that there's this tendency in our society to think that vegetables have to be fresh vegetables from Whole Foods, or we have to eat all organic. And I think sometimes it's resetting people's mindset that it's okay to eat canned fruits. It's okay to eat canned vegetables. That's better than not getting those nutrient-dense foods at all. And I also think that Erin Scalorn gave a great talk in our first discipline group session where she was talking about how you have to have your basic needs met before you can interact complex behavioral change to improve your nutrition status. But I do think that food insecurity is a systematic issue in this country and all over the world. And we're going to have to mobilize as a CF community to address that at a policy level.
All right, one last question. How do you reconcile these findings for those patients on ETI who are still struggling with appropriate weight gain?
You know, I think that this was a pilot study and we do need larger samples to get more data. I think that outside of any research we're doing, we know that people with CF need more help and support from our team to eat better diets and have better diet quality. And I think that this is where we as clinicians use our motivational interviewing skills and try to find what motivates patients and what works for them and their lives. And dietitians are the members of the interdisciplinary care team that are uniquely trained and positioned to do this. And we have longstanding relationships with our patients. So it's wonderful to be doing the research and the quality improvement interventions and the things that are happening at scale. But a lot of the magic is really happening in those clinic rooms with us and our patients. And I think that we should really be leveraging telehealth so that we can meet with our patients more frequently. It's really, really hard to support people in making changes to their diet when you only see them once every 3 to 6 months for 15 to 30 minutes at a time.
Thank you. We just got one more question in. Do you feel like the 10 participants in your study are a good reflection of the general patient population? So we can extrapolate that if education is provided, we can expect similar changes in HEI as you found in your study.
That's a great question. You know, I think that the people who chose to be in this study were probably patients who were fairly interested in nutrition. So I don't know how generalizable it is in that sense. We did have a nice spread of socioeconomic status, of BMI, of clinical status. So that was encouraging. I do also need to highlight that our sample was from a center in the Deep South. And so this might not be applicable to other regions of the United States and potentially not globally, but I hope we can get more funding to do bigger things with this.
Thank you. We hope so too.
Thanks so much.
Thank you so much, Juliana. Next up, we have Dr. Meg Sate. She comes to us from the pediatric program at the University of Texas and Southwestern Children's Medical Center.
Well, good morning. First, I'd like to start by thanking the moderators for inviting me to present the results of our phase 1 study of ANG003, a non-porcine pancreatic enzyme replacement, or PERT. And my presentation is really going to focus on the results of the lipase. Here are my disclosures. I do receive grant funding from Anagram as well as the Cystic Fibrosis Foundation. So ANG003 is a novel non-porcine microbially derived PERT that has been engineered to have stability in physiological pH ranges of 3 to 7. Similar to all PERT, ANG003 contains lipase, protease, and amylase to manage fat, protein, and carbohydrate malabsorption, respectively, in patients with cystic fibrosis and exocrine pancreatic insufficiency, or EPI. The key element in ANG003 is the ability to deliver a stable and active lipase synchronized with maximal points of fat digestion and absorption to optimize nutritional benefit. The lipase was newly designed in this product using AI machine learning to guide site-directed amino acid mutagenesis, A small number of sites were mutated, leaving ANG003 lipase 97% homologous to the naturally occurring lipase, but allowing for the creation of a lipase that has the stability and immediate activity in the stomach and the proximal part of the small intestine. The lipase remains active throughout the small intestine and then degrades as it moves down through the GI tract. We have never known exactly when the optimal time is to give PERT, before, during, or after a meal. ANG003 was specifically designed to be taken with a meal and to be active in the pH of the fed stomach. This has the advantage of acting immediately and benefiting from the churning action of the stomach for optimal interaction between the enzymes and food. Of note, previous clinical data on ANG003 protease and amylase already informed efficacious dose range for these enzymes, and so they were not altered in this product. To really understand the efficacy of ANG003 lipase dosing, we utilized the omega-3 substrate absorption challenge test, or the omega-SACT. It is known that fatty acid abnormalities, in particular DHA and EPA, the omega-3 fatty acids, play an important role in disease progression and are low in people with cystic fibrosis and EPI. Dietary fats or triglycerides must be hydrolyzed by pancreatic lipase into free fatty acids and monoglycerides before they can be absorbed in the proximal small intestine. DHA and EPA are amongst the most challenging dietary fats to absorb. Therefore, measuring their digestion serves as an excellent marker of the efficacy of any lipase. The omega-SACT measured blood levels of DHA and EPA fatty acids following a fixed high-fat meal containing known amounts of DHA and EPA, reflecting the degree of lipolysis and absorption that occurred. The omega-SACT also serves as an indicator of total fat absorption. The omega-SACT was previously used as a positive predictor of long-term absorption and clinical outcomes, including GI symptoms, weight, and height in the approval of Relisorb. So if you'll recall, Relisorb is a digestive enzyme cartridge containing a lipase that is immobilized to a food-grade bead. Liquid formula passes through Relisorb, which digests greater than 95% of fats in liquid form prior to ingestion. The lipase and the beads remain in the cartridge, and patients receive greater than 95% fatty acids and monoglycerides from the liquid formula. The omega-SACT was used to evaluate plasma absorption of fatty acids, in particular DHA and EPA, in the development and approval of Relisorb to better understand acute lipolysis and how this might translate to long-term outcomes. An approximately 20 microgram per milliliter difference was seen in the absorption between placebo and Relisorb, which also resulted not only in normalization of DHA and EPA, but achievement of desirable range within 90 days or 3 months, normalizing DHA and EPA levels in these patients. This in turn resulted in improvements in weight and length over the course of 1 year, with maximum peak noted during 6 months. Preclinical data in the exocrine pancreatic insufficient pigs shows that measured absorption of DHA and EPA is similar to full range of fats, and the peak of digestion and absorption of omega-3 fats was 4 hours after ingestion, and that the easier to digest total fats was approximately 2 hours with ANG003 80 milligram dose, 160 milligram dose, and Creon. Without enzymes, DHA and EPA and total long-chain fatty acids were absorbed minimally. Note that the X and Y axes are not the same in these two graphs because the time course of absorption of omega-3 fatty acids is longer, and the amounts in the blood for absorption of DHA and EPA is smaller than for total fats. So diets can be totally controlled in pigs, but not in humans. So it's impractical to measure total fat absorption in humans. Because DHA levels fully reflect intake, and most non-Alaskan Americans have low dietary DHA intake, a specified dose of DHA and EPA can be used for the omega-SACT, and we feel confident that it reflects absorption of the full range of fats. So on to the study and what you're waiting to hear. So the aims of our phase 1 study were to evaluate the safety and efficacy of ANG003 enzyme dose combinations in approximately 50 patients with cystic fibrosis. Please note, while we did study dose ranging for protease and amylase as well, I'm only presenting the primary endpoint in this presentation, which was the use of the omega-SAC to clinically evaluate relative markers of absorption for the engineered lipase. Second was to evaluate markers of enzyme efficacy in the context of a mixed meal with known amounts of DHA and EPA for the lipase. And we also did this for the protease and amylase. And finally, to provide information to guide dose selection of the lipase, protease, and amylase for the phase 2 study. So here's the design of the phase 1 study of ANG003, a broad spectrum PERT of microbially derived lipase, protease, and amylase. Rather than measure malabsorbed nutrients in stool, we developed a blood-based pharmacokinetic-like test to measure absorbed nutrients in blood after a specified substrate was given in the context of a mixed meal. So this is what is called the Substrate Absorption Challenge Test, or SACT. At the request of the FDA, subjects remained off their regular PERT 24 hours prior to each of the 2 SACT periods. During the first SACT period, no PERT was given with the breakfast meal. Subjects remained off PERT for the next 24 hours of the SACT. During the second SACT period, the 3 enzymes were delivered simultaneously in separate mini tabs so that the dose response of each could be assessed independently. That is, we performed SACs on the lipase, protease, and amylase simultaneously. Here is the breakdown of the omega-SACT meal. It contained 48 grams of fat. 4 grams of the total amount of fat were provided as capsules of omega-3, DHA, and EPA. This was along with 38 grams of protein and 80 grams of carbohydrates. You can see the result of the SACs for the proteins and carbohydrates in poster 607 and 671, respectively. I will really focus on the omega-SACT results. So fatty acid changes in DHA and EPA, as well as total C14 to C24, were measured over 24 hours using ascending doses of the new lipase. Each enzyme was provided in separate mini tabs. Each mini tab of lipase had 20 milligrams, so the lowest dose group got 1 mini tab of lipase and the highest dose group got 6 mini tabs. So our key inclusion and exclusion criteria: subjects were greater or equal to 18 years of age, subjects had EPI confirmed with a fecal elastase of less than 100 grams, and subjects had to have a BMI of greater than 20 to enter the study. Demographics were not different from the adult CF population reported in the registry, with about 50% taking acid suppression and more than 90% taking CFTR modulators. We also had about 30% of patients with CFRD. Adverse events were generally mild and transient and mostly tied to the off enzyme period. There were no serious adverse events reported, and a full reporting of adverse events is presented in poster 614. We evaluated 50 subjects and collected blood at 0, 1, 2, 4, 6, 8, 12, and 24 hours after the mixed meal and substrate. Subjects served as their own control, and these are the graphs for the 24-hour area under the curve and the Cmax, and you can see the changes in the values that were given when ANG003 was subtracted from the base values. The data showed that ANG003 significantly improved absorption of DHA and EPA with the 40 milligram, 80 milligram, and 120 milligram of lipase. Similar responses were seen at 10 to 12 hours and 24 hours for both area under the curve and Cmax, suggesting that the 24-hour period of blood drawing would not be necessary in future studies. A significant difference was noted between doses 1 and 2 and doses 3 and 4, with doses 3 and 4 the higher doses of 80 milligrams and 120 milligrams being most efficacious. Of note, the magnitude of the response was similar to that observed in the EPI pig preclinical studies and in the development of Reliazorb. Normal DHA and EPA concentrations ranged at approximately 65 to 85 micrograms per milliliter. Although we are using omega-3 fats as a marker of total fat absorption, a single dose of ANG003 brought DHA and EPA levels into the same range as the healthy population. In fact, all 50 subjects showed DHA and EPA levels significantly increased with ANG003 in about 4 hours after dosing. In addition, the increase in DHA and EPA to normal range was sustained above baseline and within the healthy range for 24 hours. Note that the baseline DHA and EPA levels for all of these subjects is below this range despite being on PERT supplementation in all and CFTR modulator use in greater than 90% of the subjects. It is recognized that during the study, a known amount of 4 grams of DHA and EPA was provided, which may be different and probably is than the subject's regular diet. It is suggestive that all patients taking ANG003 DHA and EPA levels in the bloodstream would be optimized with ANG003, and if they were taking enough DHA and EPA in their diet, the levels could reach normal range. This would obviously need to be explored further in future studies, but is interesting to think about. So in conclusion, a single dose of ANG003 lipase significantly improved DHA and EPA absorption in a dose-dependent manner. DHA and EPA increased above baseline to within a healthy range with only a single ANG003 dose. These data, along with that of our results for protease and amylase dosing and the ANG003 safety data, will inform the design of the phase 2 study. So in terms of next steps, finalize discussions with regulators about phase 1 and specifically about regulatory requirements as we plan the initiation of an international phase 2 study. The goal is to have a single tablet per meal and a rapidly disintegrating tablet formulation as well for the phase 3 studies. The RDT prototypes have been tested in various liquids of varying pH and have shown stability up to 60 minutes. Having a single tablet and an RDT would significantly decrease burden of disease by decreasing the number of pills required to be taken with each meal and each snack. And making the PERT in the RDT form would be easier overall, especially for our younger patients. There is also a need for non-porcine enzymes that are clinically effective, especially for those with pork allergy, and also to provide more choice for those who have religious exemption or just prefer non-animal products. The PERT available on the market today is essentially the same as it was in the 1970s. So we hope that this work will give persons with cystic fibrosis a more modern option to treat EPI and decrease disease burden. Thank you.
Thank you so much.
Hello, Jade, University of Rochester. Does early data show anything about like relation to risk for fibrosing with this product compared to a traditional enzyme?
So the phase 1 study only gave 1 dose, but the data from pigs hasn't shown.
Okay, we have, for the tablets you mentioned, younger patients, can these be crushed for infant use?
That's a good question.
Thinking ahead.
So the idea of the tablets would be that potentially they could be split in half for a snack dose, and they would be in tablet form. The RDT could potentially be, well, not potentially. The RDT can be dissolved in a liquid, and so that would be a mechanism we would be looking into more for infant use, because you could theoretically dissolve it in the formula.
Okay, being a dietitian and knowing the changes with the CF diet, I think of our patients eating more protein. That's been discussed. Are we ever going to get to a point where we're dosing enzymes maybe based upon protein and not fat? This is my little question. My mind thinks. Patients ask that too. Okay, good.
Well, I think from Dr. Borowitz's lecture yesterday, we have a good idea of the protein dose that's needed to make sure that they're absorbing an appropriate amount of protein. The reason we dose a lot of times on lipase is not just because of absorption, but because malabsorption results in steatorrhea and the discomfort and diarrhea and all that they experience. That's why really the focus tends to be more on the lipase than the protease. But Drusi's going to add to my response.
Drusi Borowitz, I do have a conflict of interest. I am on the board of Anagram that makes this enzyme. But I think getting to your question, it's like, how does one dose enzymes? So first of all, it just warms my heart. I mean, coefficient of fat absorption absolutely can tell the difference between no enzyme and enzyme. It's just dichotomous. If you ever read anything that I wrote where I ever said, use CFA to dose enzymes, just ignore it. It's so wrong. CFA's never been shown to correlate with growth. It's never been shown to correlate with dose. It's a bad endpoint. And so this is fantastic. But if you think about dosing, when you eat a meal, your pancreas puts out an enormous amount of lipase and protease. And so I just think this idea of somehow we need to, I hate the word titrate. It's like ridiculous. We don't, for example, inhaled tobramycin was developed, we looked at 95% of the isolates of, 95% of the isolates of Pseudomonas had to be sensitive to tobramycin. And that's how the dose was chosen. We don't say, well, if you have a little cough, we'll give you a little dose. And if you have a bigger cough, we'll give you a full dose. It just isn't the way the body works. So I think this idea that somehow, we would be really good clinicians if we adjusted things, it's a little bit like pediatrics in the 1930s, where people would make a formula with this much milk and this much Karo syrup and this much water adjusted to symptoms. It's just an old way of thinking about things. So I think we should be thinking about quality of diet. That absolutely is, it's wonderful that ETI is getting us to that point. But I don't think we have to dose based on exactly what's in the meal.
Thank you, Drusi.
I can feel the brain power exuding back here. Drusi. I was like, because these are all great points here. Number one is on the protein, there are other peptidases and things. And plus, you're not trying to make a micelle and have bile and all these things that are critical in lipid absorption. So that's why I think we tend to focus on the lipids. And I think there's more just comment, but, this rational approach of not just come up with a recombinant enzyme, but how can you have readouts that, as Drusi was just saying, get at dosing? And I think this will be important. There was the question about, fibrosing colonopathy. So again, I think, if you can develop a better assay, which is what's being done with the Anagram platform here, that will inform what is the right dose as opposed to just pouring in massive amounts of these enzymes and we're just shooting from the hip and not sure how much to give. And we heard in the prior talk, we should be giving the right diet. So we also have the background of the diet moving because you guys as dietitians are doing great things. So we got to recalibrate all these things. And I think, Meg, to your credit and with the team, you're coming up with rational approaches that are robust to look at what is the right dose to give.
Thank you. There's one more question that came through. Did you track GI symptoms, and did you feel that the symptoms were resolved?
So we did track GI symptoms, and that data is to come.
Future conference topics right here. All right.
But remember, it was just one dose.
Yes. All right. Thank you, Meg.
Okay, next up, we have Dr. Terase Thomas. She comes to us as a fellow from Nationwide Children's Hospital.
Can everyone in the back hear me clearly? I would like to thank the NACF committee for the opportunity to speak here today. I would spare you by reading my lengthy title of this talk and just say this talk will be about a modified screening tool at my institution that was implemented to look at problematic behaviors among our CF infants and toddlers. I have no disclosures to make. The objective of our project at our institution was to identify problematic eating behaviors early. Also, to implement targeted interventions that could prevent future nutrition concerns. By a show of hands, how many of you that take care of CF patients realize the problematic feeding behaviors that they have from an early age? Great. With that, how many of you utilize a screening tool for these behaviors? I see less hands, maybe one. Well, the feeding assessment that was first looked at for us was the Behavioral Pediatric Feeding Assessment Scale. And it was utilized because it's easy to be modified as it assessed for problematic feeding behaviors, and it was designed for both normative as well as clinical populations. In addition, it is a reliable and valid measure that effectively discriminates children with clinically significant feeding problems, such as preference for particular textured food or refusal to eat in general. The original assessment is divided into two sections. The first section reflects the child's behavior. How is your child eating? Does he enjoy eating? Does he have a problem with chewing food? These questions are based on a Likert scale of 1 to 5, with 1 being never and 5 being always. The second portion look at the parent's behavior towards their child during mealtime. Questions such as, do you use threats to get your child to eat? Or have you force-fed your child? These factors tap into various aspects of feeding difficulties, including oral motor problems, food selectivities, and just problematic feeding behaviors in general. Overall, studies have shown that problematic eating is more stressful for parents of CF children compared to non-CF children. With that said, there was one study that I was able to find that looked at this screening tool in children with CF. The study showed that basically children 12 to 23 months old who were included in the study did indeed have problematic feeding behavior. Specifically, there was about 60% of children that were identified out of 103 children. I will, however, mention that the challenges with this screening tool, particularly with children with CF, is that the complexity of feeding disorders with this patient population is that there are a combination of medical, nutritional, as well as psychosocial feeding issues. In addition, the diversity in feeding problems, such as dietary diversity, to recognize that we have a patient population that is global as well as different ethnicities. The reliance on enteral nutrition is important, and a complete assessment of the process is needed. This kind of brings back memories to childhood for me. I wonder if I was not such a picky eater, if I would maybe be a couple inches taller. Gonna be realistic. I didn't expect I would be playing in a WNBA with the New York Liberties, but maybe a couple inches. Mealtime can be frustrating for parents, and it can be a struggle. We can see that for children with CF, because of their medical complication, there are implications towards them if they have problematic feeding behaviors. So prolonged meal times can lead to increased energy expenditures during eating, potentially offsetting some of the caloric intake. Extended meal times may interfere with the timing and effectiveness of enzyme supplementation. Therefore, it's invaluable that implementing behavioral strategies to improve eating efficiency is essential. Providers can review strategies such as structured meal times, limiting meals to about 15 to 20 minutes in order to create a more positive environment around eating. Our methods that we use, as mentioned, was to modify the BPFSA screening tool. The second portion of the original assessment was where most of the modification occurred. Such questions such as ease of taking pancreatic enzymes, is your child still using a bottle by the age of 2 or more? And where is your child eating at mealtime? Are they running around and grazing and feeding themselves, or are they in a high chair in a structured environment? The screening process took place with patients when they were at 9 months, 18 months, 24 months, and 36 months of age. The survey was conducted during the visit. We all know that CF visits can be a very busy time, and having this thorough assessment in place gave the providers the opportunity to recognize key problematic behaviors to address during that visit. It is to note that this modified tool was crafted by our knowledgeable dietitians who have close to 80 years experience, longer than I've been on this earth. Also our medical providers, child life specialists, as well as our mental health coordinators. They were able to help us identify red flag behaviors, which I will get into more later. And also in order to help us to refer to developmental appropriate interventions. These are some examples of the red flag behaviors that we highlighted. Refusal to eat, negotiating during meals, prefer to drink than to eat solid food, their preference for Pediasure or other forms of liquid, throwing tantrum during meals, or getting up frequently during your meal. For our age group of 9 months and 18 months, over 59 visits, there were about 40 caregivers that participated. As you can see, 27 of those caregivers, which was about 68%, reported red flags. The range of behaviors that were reported per visit was from 1 to 9, with the median being 1. Similarly, for the 24 and 36 months, we saw that over a course of 77 visits, that 37 caregivers also reported red flags, and the range was also from 1 to 9, with the median being 2. For our clinic, the most prevalent red flag behavior was mealtime lasting longer than 20 minutes. It also showed that there was a progression over time. Other common and prevalent behaviors that we saw was choking and gagging with feeds, as well as pocketing food in their mouth. I would say our group was able to identify feeding behaviors highlighted in the survey and was able to talk with families about interventions, whether in-house or referral to external sources, including behavioral health specialists, speech, feeding, and occupational therapy. In conclusion, I would say that we had success with this modified screening tool in our clinic in identifying problematic feeding behaviors for toddlers and infants. If you like, you can scan the QR code on the right, which gives you access to the modified screening tool. And except for the one person that raised their hand, you can also use this in your clinic.
Okay, any questions?
Did you utilize, I know this was a study, but did you utilize feeding therapists after getting red flags and see if that provided more benefit than just intervention through the clinic team?
Yes. Yes, we did. Like as mentioned, there's more data to come.
Hi, that was great. Jessica Alvarez, Emory University. I was looking at the feeding behaviors and thinking of my own children and wondering, how do you differentiate between just general feeding behaviors in children, in the general population, versus these specific to CF?
Well, I would say that these behaviors are very common to normative children versus our clinical population. I would say the key is how these behaviors can grossly affect their disease outcome, such as mentioned, if they're having prolonged eating time, this affects your enzyme replacement. So it's not so much that there are different red flags, it's just identifying which particular red flag can have the most devastating outcomes.
Thank you for the talk. I have used the tool in my practice and identified quite a bit of eating behavior referring to therapists for either OT or speech, but often they're only getting an hour a month. I know that's not sufficient, or their weight, or because they don't qualify for school. When I'm stuck in that situation, what would you recommend?
Well, I think that you sound like you're doing everything you should do. It is ideal to mention, and I believe our second talker, Juliana, mentioned that there are a lot of pitfalls to our healthcare system still. I do not believe once a month is sufficient, especially for dietary guidance. I wish that we had more telehealth appointments available and that more therapies were done more frequently, but that's something for future studies or possible recruitment.
Dee Friedman from Harvard, that was a great talk. It's not my area of expertise, but how correctable are these behaviors as a function of age? So if you pick this up at age 2 or 3 versus age 7 or 8?
Well, the idea that we were trying to find, and as I said, this is still ongoing, is that we're starting from the age of 9 months because we believe, and based on what we saw, that the earlier that it's detected, the more correctable it is. And as mentioned, starting early does impact how their disease progress.
Thank you for your talk. I'm a little tall, gotta pick this up. I wonder if you looked at, you didn't mention it, but if you looked at or considered looking at feeding structure in the home and how that affects what you're talking about.
Yes, that was briefly kind of looked at in the survey and briefly mentioned. One of the questions in a modified survey looked at who's feeding a child. Sometimes is it the parents or are they leaving it up to the teenage sister or brother? Also, are they in a high chair or are they just running around grazing? So part of the guidance that the CF team does give to parents is creating structured mealtime, specific times for eating, and other behaviors that can be managed by the family at home.
Anne-Marc from France. Have you looked at the parents' anxiety and distress?
Yes, and I would say that we kind of feed into that monster because from infancy or when they were diagnosed, we have stressed the importance of high-fat, high-protein diet, which I'm learning now might need to modify that. So we also create this extra anxiety for these parents. And it is good that we have this survey because, as mentioned, parents are able to reflect on these moments, and we're also able to suggest parents are referred to specialists.
Thank you for your talk. I'm Erin from Texas. I'm a dietitian. I work in eating disorders and pretty regularly with kids with ARFID. And so I just wanted to share, at least for dietitians in the room, if you want to search the responsive feeding white paper, it's a really great framework. Just like I can't fix it, but I can create safety around this. I think as you can decrease parents' stress levels with feeding, it's amazing how these kids can respond. The other resource I would recommend is RDs for neurodiversity. I know we're not necessarily talking about kids who are neurodiverse, but I really appreciate this dietitian's perspective again on just creating safety and normalizing things. Like we have patients with IBS who consume 80% of their nutrition via, formula, and we don't bat an eye at that. And yet if we have a kid with a neurodivergence and they're consuming 80% of their nutrition from formula, then that's a problem we have to fix. Again, I'd ask the question, like, is this a concern? Is this something we need to approach, or is this something we need to let be?
I appreciate that. I'll also see if I can find you to get that resource again. I think it flipped out already.
Okay, question that came through was if your survey was validated.
Well, I would love if someone could help us validate the survey, but that is also to come.
Okay. Would you, okay, spoiler, but would you ever do like multi-center studies? Like combine a couple different CF centers to be part of this?
That's a possibility. I'm looking towards my attendant in the room. Yes.
There you go. Okay. No, I love this. I love the work. And there was one more question about patients who had responded to the screener, and if you ever made referrals to GI.
Yes. Something to note about our CF clinic, we have sometimes we tend to cluster our patient that have significant GI complications. In those CF clinic visits, usually a GI physician is present for patients that have mostly a allergy manifestation such as sinuses. Allergy, ANI is usually present in those clinic visits, as well as other non-pulmonary manifestation of CF.
Very good. Thank you so much.
Thank you.
And our last speaker, let's welcome Dr. Anne Monk. She comes to us from Paris, France, the Necker's Infant Hospital.
Good morning to everyone, and I thank the organizer for having the opportunity to present and discuss with you the impact of a cystic fibrosis specific multivitamin formulation of fat-soluble vitamin status and treatment satisfaction in preschool children. There are no relationships to disclose related to this presentation. Just go a little on the background. Young children with CF are at risk of fat-soluble vitamin deficiency. In France, they are supplemented by individual vitamin A, D, E, and K with 2 to 4 different products. And the vitamin K1 prescribed tasted very bad, as it is an ampoule used for IV administration. Deca Plus liquid is a highly absorbable water-based formulation of vitamins D3, E, K1 and A, beta-carotene and retinol, zinc and selenium. Deca Plus liquid also contains small amounts of B vitamins and vitamin C. The water solubility of Decas is enhanced using a special form of vitamin E, TPGS, tocophersolane, and in France, Deca Plus liquid was introduced in 2022, had a very rapid uptake among the CF population. We know that vitamin studies in CF are rare, although the products and their dosing are often not known. I will go to talk a little more on vitamin A. Vitamin A can be supplemented as preform vitamin A retinol esters like retinyl palmitate, or provitamin A, it's beta-carotene. And importantly, beta-carotene is converted to vitamin A by the body only when needed. On the other hand, the use of preform vitamin A may result in excessive vitamin A dosage, supraphysiological vitamin A levels, and possible toxicity. In one study from McBall in 2008 in CF, retinol levels were over the upper limit in up to 58% of the patients. In addition, blood sampling should be performed at fasting and in a stable, non-infectious state. Dosage recommendations are mostly based on expert consensus rather than evidence-based, as it is shown in our recent update, ESPEN Guideline 2024. What are the characteristics of this Decas formulation? It provides vitamin D and K as D3 and K1 as recommended in the CF nutrition guidelines. It contains vitamin E as TPGS, which improves
its intestinal absorption. And furthermore, it has been shown that for vitamin D and A, it also improves intestinal absorption in the context of cholestatic diseases. It reduces the burden of treatment by reducing the number of products that need to be taken by the patients. And according to the CF nutrition guidelines, a multivitamin presentation will aid in compliance. In addition, it provides vitamin A in the formulation mostly as beta-carotene. And the water-based formulation can be mixed with most beverages. We aimed at monitoring serum fat-soluble vitamin, prothrombin time, self-reported treatment satisfaction and compliance before and after the switch to the CF-specific product. For the methodology, we use retrospective evaluation with anonymous reutilization of routine vitamin levels and of visual analog scale measurement at baseline M0, month 3, and month 12. Paired observation at month 0 and 12 were analyzed with the Wilcoxon sign rank text two-sided, and the rates of vitamin insufficiency deficiency for the entire cohort at month 0 and 12 were compared by the Fisher's exact test. Patients were followed at 6 CF centers spread over France. 39 kids, all were under 4 years of age at DECA+ liquid initiation. All were diagnosed by CF newborn screening. All but one were exocrine pancreatic insufficient based on fecal elastase, and all required fat-soluble vitamin supplementation. None were taking elexacaftor, tezacaftor, ivacaftor, ETI. And the mean age at the switch was 2 plus or minus 1.1 year, ranging from 0.1 to 4 years. Considering treatment discontinuation, dosage adaptation, and adverse event, DECA+ liquid was discontinued in 4 out of the 39 cases. The reason were, for one case, recurrent regurgitations, another one, agitation, and for 2, related to the bad taste. One patient moved to the solid product form as his older brother. After monthly assessment, DECA+ liquid dosage was adapted in 9 out of 36 cases, meaning 25% of the population. And the dosage was increased in 5 cases and decreased in 4. After month 12 assessment, DECA+ liquid dosage was adapted in 1 case. One patient complained about abdominal pain but didn't discontinue treatment. This table is dedicated to the fat-soluble vitamin dosage. At month 12, the mean intake of DECA+ liquid was 2 milliliter plus or minus 0.9. Considering the dosage for vitamin D, it decreased significantly between month 0 and month 12, but you can notice also that the product moved from D2 to D3 cholecalciferol, in line with the recommendation. At the bottom of the slide, you have the recommended dosage from the recent ESPEN guideline, but it didn't change from the previous one anyway. For vitamin E, on these paired observations, the dosage increased significantly. For vitamin K, the dosage also increased significantly. For vitamin A, total intake increased significantly, but it is important to notice that the intake of vitamin A preform retinol decreased significantly. Now we will consider the fat-soluble vitamin serum levels on paired observation. For 25 hydroxy vitamin D, but the serum level increased significantly. For vitamin E, it increased also significantly, but we observed no change for prothrombin time or vitamin A. We looked at the rate of fat-soluble vitamin insufficiency deficiency on the entire cohort, And you can see that for vitamin D insufficiency, the rate is dropped from 36% to 13%. For vitamin E, it remains stable. For prothrombin time, none were deficient. And for vitamin A, a slight decrease in the percentage of deficiency. For the cutoff, we took the paper from Lay for the first study group because we couldn't find very specific cutoff for this very young population. Treatment satisfaction and compliance. Treatment satisfaction on the paired observation increased significantly, even if 4 children found that the taste could be improved and 3 parents found the pipette unpractical. Self-reported compliance was very high at both time points, but we need to keep in mind that there were preschool children, so they have no choice to take the product, possibly. To summarize the results of switch to DECA Plus liquid, for vitamin D, the dosage of vitamin D decreased by 36% to an average in line with the CF nutrition guidelines. But we have to keep in mind that we move from D2 to D3, that is more absorbable. Despite the decrease, the average serum level of vitamin D increased, and consequently, the number of patients with vitamin D insufficiency decreased from 36 to 13%. Concerning vitamin E, the dosage of vitamin E increased to a dosage in line with CF nutrition guidelines, and the average serum level of vitamin E also increased. For vitamin K, importantly, the number of patients receiving vitamin K increased from 79 to 100%, and I am absolutely sure that the prescription of vitamin K1 with the previous product with the 79% is the prescription, but not intake of vitamin K in the real life. Dosage of vitamin K increased to a dosage in line with CF nutrition guidelines and no effect on prothrombin time. For vitamin A, the average serum level was unchanged, showing that the switch from preform retinol to mainly beta-carotene does not affect the efficacy of supplementation. That's very important. And fewer patients had vitamin A deficiency. Treatment satisfaction improved. To conclude, in these preschool children, the switch of supplementation from individual A, D, E, K vitamins to DECA Plus liquid significantly improved serum levels of vitamin D and E, reduced the number of subjects with vitamin D insufficiency, had no effect on vitamin A serum levels and prothrombin time, and increased satisfaction. Monitoring of fat-soluble vitamin serum levels remains a key point, as at least 25% of this young cohort needed a dosage adaptation after 3 months evaluation. Thank you for your attention.
Tom Ziegler, Emory University in Atlanta. Very nice talk. Lots of focus appropriately on fat-soluble vitamins in CF, and this looks like an advance, as well as the other earlier talks. To go off topic, what about water-soluble vitamins? I know we don't think about them as much, but if there's problems with digestion, whether it's non-compliance or just underlying pathology, there could be water-soluble vitamin deficiency in people with CF, but I don't know how many people have looked at that extensively. So can you comment on water-soluble vitamins? Because you mentioned there were water-soluble vitamins in this product, and did you measure those?
You are correct. I mentioned it because when this product were formulated, it was based on the previous guidelines, and patients with CF were malnourished. So it is very small amount to be sure at that time that if there was a deficit, the addition of vitamin B and C could be a plus. Nowadays, it's not at all the situation, and the amounts are really small. So anyway, it may not be a problem to have that on board. But I was also wondering why we have in this product these water-soluble vitamins, but possibly for nowadays, it's not.
Any other questions? And I'm going to ask a quick question. How do you feel that your data would have been different if the CF patients were receiving CFTR modulators?
That's a very good point, mainly concerning vitamin A. So, well, our study showed that with increasing the dosage of vitamin A, but with a product safer because it contained a low content of retinol, we didn't show any increase in vitamin A serum level. But we may see some increase in vitamin A with CFTR modulators. However, when we look at the references from Laura Chambry, who collected 54 cases in the UK registry from patients aged 5 to 15 years of age, she found a small increase in those taking ETI, and only 6% had a value slightly over the upper cutoff. So it means that it emphasizes how important it is to have beta-carotene in our, mostly beta-carotene in our product. And there have been isolated case reports on elevated intracranial pressure in patients from 7 to 12 years of age. And we have little information on the product and the dosage of vitamin in these cases. And I would say that now it is difficult to be sure that these isolated cases had interference with vitamin A. It is not demonstrated. The publication from Laura Chambry is in GCF 2023, and the publication of the case report is from Southern in 2023 in the Blue Journal, one case in the Canadian Ophthalmology Journal in 2021, and another one from Wisniewski in GCF 2022. So we need more information, but the relationship between this and vitamin A is not surely demonstrated and need not be causal.
Thank you. We have one question that came through. Did you measure any markers of inflammation? And can you comment on the utility of the PT to assess the vitamin K outcomes?
PT is more, it's less accurate than INR for sure, but in France, it's what is done currently in all of the lab all over. The best way to assess vitamin K is, of course, deficiency is, of course, PK2, but this is a research parameter.
Yes, same here in the States, in a lot of places. All right, any other questions? All right, thank you so much, Anne.
Thank you all so much for coming.